right. Hi, everyone. It's fantastic to have everyone in attendance with us tonight with what promises to be a really important session. And we just wanted to start off by acknowledging the traditional owners of the land and the Aboriginal and Torres Strait Islander peoples of this nation. And we acknowledge the traditional custodians and sovereign people of the land across which we work in our respective meeting places. We respect their continuing connection to land, water, and community, and pay respects to elders past, present, and emerging. So, we're going to hear from a number of speakers tonight. I'm just going to quickly go through some of the bios, just so you know who we've got with us, and also the structure that we're going to take for tonight as well. But just before we do, just to let everyone know, there will be the ability to submit questions. So we won't have the ability for audio for people to call out questions, but you can put that in the Q&A box, which we'll be looking at throughout the night, and particularly when we come to our panel discussion. So just be aware of that. If you've got questions or comments, feel free to pop them in. And as we've got up here, the session is being recorded. So hopefully everyone is okay with that one, and there will be an evaluation form online at the end of the webinar. So just by way of intro, so I'm Chris Jones. I'm the mental health manager, one of the mental health managers rather, at Cessman. So I've got the pleasure of welcoming you tonight, and also welcoming Professor Nicole Sadler. So Nicole is the CEO of Phoenix Australia. Phoenix Australia, a registered charity in Australia's Centre of Excellence for Posttraumatic Support in Mental Health. And Nicole's a clinical psychologist with expertise in assisting individuals, workplaces, and communities to manage the impact of trauma, including following disasters and other large-scale events. So it's a real pleasure to have Nicole tonight. You'll hear from Nicole shortly. We're also really pleased to have Dr. Karen Spielman with us tonight. So many of you would know Karen. So Karen's an established and experienced GP who practices in Paddington, has worked in the Cessman area for over 25 years. And Karen also has a special interest in support of young people's mental health and eating disorders. Karen's also involved in GP advocacy research, peer group facilitation and teaching. And Karen was also recently appointed the RSCGP Psychological Medicine Specific Interest Group Chair. So Karen will feature shortly as part of a panel with Nicole. And we've also got Alex Howard. So Alex is the Director of Disasters and Public Health Emergencies from Phoenix Australia. And Alex will moderate the panel discussion that we'll move to in a second. So you'll hear from Nicole for around 10 minutes. And then the majority of our session there will be the panel discussion featuring Karen and Nicole. So with that all said, over to you, over to you, Nicole.
Lovely. Thank you so very much, Chris. And thank you for the invitation to join you this evening. I am joining you today from Bondi land here in Victoria. I'd like to start off by acknowledging that people on the call will have been impacted in some way by the terrorist attack, and many of you will have already been providing support over the past couple of months. The aim today is to give you some really practical guidance and information which is relevant to this post-event stage, so a couple of months on. Expect that for some of you, this will just be a reminder of things you already know, or maybe even some reassurance that what you're doing is on the right track. But it is a good opportunity to stop and to think about what it is that we're doing, and perhaps what we should be doing to make sure that our practice is always trauma-informed. Next slide, please, Chris. So we're going to focus very much on what people may be experiencing at this 2 months mark and risk factors for ongoing concerns. We will be giving you more information, resources throughout this chat function, but also you'll get some more information later through the PHN and other sources. So we're not going to try and cover everything now, but give you links to other things that might provide you with more information. I'm going to start by spending just about 10 minutes on some general information, but the focus of this session is keeping it very practical rather than theoretical. If you like, please feel free to put what your profession is in the chat so that we can also tailor the information to our audience. And as Chris has said, please, if you have any specific questions, feel free to pop them in also. Someone's saying that they can't hear me. I think, Chris, you can hear me okay? Okay. And so we're going to be talking about what it is that you're likely to be seeing, what are the risk factors for ongoing impacts, and then what is trauma-informed care principles, or reminding you of what they are and how you can apply those to your role. And as Chris has already said, we will spend most of the time in a panel discussion. Next slide, please. Okay, so 2 months in, what we will have seen is that people will have moved beyond the acute stress reaction that they would have experienced in those initial days or weeks. But it is very likely that you're still seeing ongoing stresses or secondary traumas, and that you will see them, or people will report them across all of these different functions. So in the way that they're thinking, their body or physical changes, their behaviour, emotional changes, or changes in their relationship. People will be impacted in different ways. Reactions will vary greatly from person to person, and they're also likely to change over time. So, for example, someone who may have been very fearful to start off with may now be reporting more anger or frustration or irritability. When you're assessing people, don't presume that the level of impact or their reactions will closely align with how close they were to the event. You need to understand, what was the meaning of the event for that person? What was the extent and the nature of their involvement? If we think about just at the really highest level for this particular event, for some people, they were targeted by terrorists. So for them, it was a very specific terrorist attack. Other people were bystanders. Other people are part of an impacted community. Perhaps they weren't there, but they've been impacted by it. Other people were first responders. Other people have a loved one or a colleague who was impacted. So people will have been impacted in very different ways, and that will also impact the meaning and perhaps the level of that impact. For some people, we will start to see them transitioning from reactions to perhaps subsyndromal or even mental health conditions. And the sorts of things that we might be thinking about or looking for might be things like distress, anger, fear. Some people may still be having a lot of trouble articulating how they're feeling or their reactions. Some people may be talking about feeling very numb, that they can't access their reactions or their emotions. Some people might still be talking about things like difficulty concentrating or taking in information or remembering exactly what happened or the sequence of event. Some people might be talking about very functional things like changes in their sleep or their appetite. Some people will want to share a lot of information with you, and some people will not want to talk about it at all. Some people will be very withdrawn. Some people will be talking about things like survivor guilt. Why did I survive? Why wasn't I injured when other people were? And for some people, they won't talk about the trauma at all, but they will talk about very somatic things, physical ailments that they're experiencing. So it is about having a conversation with people or being aware of perhaps how they may have been involved and trying to understand the meaning of it, as well as the impacts. Even a couple of months later, when people are talking about symptoms, we still know that most people will continue to recover by drawing on their usual coping strategies and social support mechanisms. Thanks, Chris. We also know that for some people, when events have been particularly overwhelming, or if they're repeated or denied or not acknowledged, it can lead to longer-term impacts. Now, in the case of trauma, definitely what we might see is some people starting to meet the criteria for post-traumatic stress disorder, but it is just as likely, if not more likely, that some people will be meeting criteria for anxiety or depression or substance abuse. Or sometimes what we'll see is that all of those things may be present. But for a lot of people, what we will be seeing now are the subsyndromal symptoms, which are impacting their quality or functioning. So these things are not meeting diagnostic criteria at this stage, but they could go on to meet diagnostic criteria, and in particular be watching out for things like disturbances in sleep, anger or irritability, substance misuse, relationships problems, difficulty meeting their responsibilities, their parenting, ability to stay connected at work or in the community. And of course, sometimes we see it really starting to affect psychosocial things, financial stress, housing instability, isolation. So you're really starting to look at what are people reporting, and has the intensity and the frequency and the impact on functioning, has that resolved, or is this still, or is it escalated, or is it problematic for people? And at this stage, if people are reporting things which are impacting functioning, is thinking about, does this person need a comprehensive mental health assessment to get the right diagnosis and then to get evidence-based treatment according to what it is that, the conditions that they may be facing at that point in time. By looking at all of this in a trauma-informed way, it helps us to understand that these responses are not signs of weaknesses or failure, but rather very much understandable outcomes of what they've experienced. And we need to be able to, of course, respond to those in ways that are safe, respectful, and supportive. Thanks, Chris. As we're starting to see people transition from initial phase to emerging mental health conditions, it's useful just to remember that there are risk factors that can put people at greater risk of ongoing impacts. They occur before, during, and after. We know that whilst most people will recover well, up to a quarter of people who've experienced a significant trauma can go on to develop a diagnosable mental health condition. And we do unfortunately see higher rates after terrorist attacks. Individual factors in terms of recovery are impacted by all sorts of different things, but be really mindful of these, knowing what was their history in terms of their medical, their physical health, their psychological health, how socially well they were connected even before the event. Many people have been dealing with very significant traumas for long periods of time before the Bondi incident. Think about what happened to them during the event, the nature and severity, predictability, how they initially responded, and again, the frequency and the intensity of those responses and how they may have shifted. And then what do they have around them at this point in time? What are the other stresses that might be happening for them? How much social support do they have? You will notice that across all three of those sections, social support is key. We know that the best predictor of people's recovery at all three stages is the quality of those social supports that they have available to them. Next slide, please. This is a really brief reminder. When we talk about being trauma-informed, it's a framework for service delivery that supports safe and positive experiences for people who've experienced trauma. We think about ways of cares that promote healing and growth, that meet the needs of the individual, but also acknowledges that workers, all of you, can be impacted also. So we need to be thinking about policies and practices that support worker wellbeing and safety, as well as clients and patients. And trauma-informed, it isn't about prescribing specific procedures, but rather it's a set of guiding principles that encourages you to always be thinking about the impacts of trauma on this individual and what might that mean about their ability to really engage with the services that you're providing. Thanks, Chris. Next slide. Can we go back one? We seem to have lost the details of one of those slides there. That's okay. Look, when we think about being trauma-informed, we really think about the needs of the individual, and we think about a few very specific things around how do we make sure that people are feeling safe psychologically and also physically. How do we encourage a sense of control? Safety and control are things that get disrupted when someone is exposed to a trauma. We think about things to do with their ability to have calm, to be able to self-regulate, to be able to feel like they're able to bring physiological symptoms and psychological symptoms under control. We think about social support. How do we link people to the supports information or referral information that they require? How do you encourage healthy coping strategies with them? And how are you making sure that you're aware of the risk factors relevant to them so that you can be mindful of them and keep monitoring them? And we need to do this in the context that you are very busy. The reality is that many times you will be seeing people where mental health is a part of, but not necessarily even the primary focus of what it is that you're seeing them for. The reality is that you often have only brief appointments. So we're about to have a panel discussion where we'll talk about some very specific examples of how can you just make small adjustments to what you're already doing, to be making sure that what you're doing is trauma informed, rather than saying you need to do a whole heap of additional work. I'm now going to invite Alex and Karen to join me for the panel discussion where we'll discuss some of those things in more detail. And thank you to Alex who's putting those principles in the chat for you also.
Great, thank you, Nicole, and very well managed when the diagram that you expected to be there wasn't there. So just to kind of recap those trauma-informed principles, we'll make sure you get a copy of the nice graphic, but at the center we say being trauma-aware and culturally responsive. And then around that, talk about building safety and trust, choice and control, believe in recovery, whatever that may look like, focus on strengths and facilitating connections. And a really key part of trauma-informed care is ensuring your own well-being, which we'll hopefully get a chance to touch on, and ensuring that there's organisational support as well for the work that you're doing. So I'm fortunate enough to be able to be kind of facilitating this discussion with Karen and Nicole. I'm very much looking forward to their insights. And Karen, I'll have the first question for you. And Chris, you can stop sharing the slides if you'd like, actually. So Nicole has spoken through some, what we know from the research and from the evidence we might be expecting to see a couple of months on after an attack like this. Be really interested to know, from your experience, how does this fit with what you've been seeing in your clinic? Who is coming to see you? What are some of the things that you're noticing? So, yeah, any reflections that you have, Karen, would be really great.
Thanks, Alex, and thanks, Nicole, for such a terrific presentation. I feel like my life has flashed before my eyes. It's like such a beautiful potted summary of what we've been going through, not just since December 14, but I think since the pandemic for GPs particularly. I think probably my colleagues and I and others in the community have become really very aware of the importance of trauma-informed care and meeting people where they're at in very much in that model. So thank you for sharing it with us so beautifully. Alex, I think, what have I been seeing? Well, I work in Paddington, as Chris said. It's kind of outside the major centres of the Jewish community in the eastern suburbs, but it's on the periphery of it. And I'm Jewish, and I have a lot, not a huge number, but a significant number of Jewish patients. But when I came back to work after December 14, I started talking about the incident with my very first patient. And I didn't stop for about 2 weeks. And every single patient had an experience. It kind of, ebbed and flowed through the fortnight, and it's certainly still going. But just as a little example, my very first patient was a young woman who I've seen for about 20 years. I've looked after for a very long time, who lives in Bondi. She's not Jewish. She wasn't at the event, but she was on her way back. And she had some vulnerabilities that made her very sensitive to what had happened. And so I kind of sat down and put my big girl pants on and took a deep breath, pulled down, every kind of resource that I've gained over the last few years and, in many ways, my entire career. And brought my whole self into the consultation and focused very much on where she was at and very much in the way that you said, Nicole, but recognizing when people come in, what I've been fortunate to be in the same practice for nearly 20 years. I know my patients really well. So before they walk in, I've got a pretty good idea of what their connections going to be, and that's a real gift. And I hope many of you are in the same position, but not everybody is, obviously. So best being aware that people from all walks of life have been hugely impacted by our safety being really shattered on our doorstep, and been hearing about it for a long time, and to actually we've had various degrees of experiences personally, but this is very close to home, very much in our face, and very much impacting everybody. So from my Jewish, non-Jewish patients, young, old, people who were there, people who weren't there, people who are caregivers, people who are first responders, people who are just in the Jewish community who've experienced layers of feeling unseen with the increasing threats that have come closer and closer to us, and the political unrest and October 7th. So there's the community's very vulnerable, very frightened, and very impacted. So I could keep going, but I might.
No, that's really. I think it's just really important to kind of hear. It's all very well to know what we expect to see, but then to understand that reflects your experience. And it sounds like, for every person that has walked through your office since the attack and really prior to that, a different meaning for the event, a different set of reactions. But I think what you're also reflecting is that, because your clients so well, or many of them, looking for those changes, understanding their history, and as you say, understanding people's particularly vulnerability to being impacted, even though, if you were to not know those things, you might be like, well, they weren't directly impacted. So, maybe this will be a lighter 15-minute appointment, but not being able to anticipate that. I think the other thing that we wanted, and look, this is obviously a longer conversation, as you say, but there were, as you've said, there are many communities who have been impacted in different ways, but we know that this attack was targeted at the Jewish community. And one of the cultural aspects of being trauma-informed, and if we could have seen the diagram, we can see it right in the middle of that diagram, is being culturally sensitive as well as trauma-aware. Knowing that, this is a larger topic, but for the people who are kind of taking the time this evening, what are some of the key things that GPs and other practitioners and others supporting who might be listening should understand to better support people who are Jewish in their caseload, in their community?
Thank you for asking. Look, it's a difficult answer. Where I would start with is just to really recognize that people express and relate to their Jewishness in myriad ways. We have an old joke that says if you've got 3 Jews, you've got 5 opinions, and it's the same in terms of how we identify and how we connect to our community. Sadly, there are some stereotypes when people are uneducated or misinformed. But really, our community is incredibly diverse, just like everybody else. And people are religious or secular. Some of my friends and colleagues have got family who've arrived on the first fleet. I'm not joking. And some of us have arrived in the last generation or two, and there's ongoing waves of immigration. And sadly, most of that is because of persecution. Not always, but there's often levels of trauma that come with that we kind of carry with us, and people connect to that in different ways and in varying ways. So I think just being aware, you don't know who of your patients are Jewish unless they self-identify. Being careful about that, is, I think, really important, not to make assumptions that people are religious or secular, or that they belong to a particular part of the community. And that many of, I want to say many of us, I'm a bit loud and proud, but many of us have been scared to share their identity, certainly professionally as well. And so being sensitive to that, because we cannot necessarily rely on the community or sometimes colleagues to be culturally sensitive. So we have got that level of fear and hypervigilance, many many times. So, being, I almost think, like we have our rainbow flags and we have our whatever it is. It's almost, some of us have kind of been joking about, do we need some kind of thing like that you're culturally aware? I mean, I don't know. That's another whole conversation. But just being aware, no stereotypes, no presumptions, and not everybody has the same political views, of course. So
Yeah.
being really trauma aware is really seeing the person in front of you and asking for their connections, and I would hope that we would get the same respect that we give to other cultures and minorities and intersectional.
Yeah. And I think that kind of that point has come up a few times, of just really not making assumptions about the person in front of you, full stop, in terms of what being Jewish means to them or what the event means to them as well. So I think that's really important. And if there are resources, and maybe we can kind of connect to the PHN separately, knowing that, as I say, it is really central to trauma inform to be culturally responsive, and that is an ongoing kind of process of education as well. So, and there might be some more specific questions that people have that we can come back to. So, I guess almost following on from that idea of that attack being targeted to that particular group, one of the one of the key features of terrorism is that it is intended to deliberately destroy individual, community, however we define community, a sense of safety. So just thinking, Nicole, I might get your thoughts initially. So it makes it even more critical that we think of that principle of rebuilding safety and trust as one of the key principles of trauma-informed care. From your kind of discussions and observation, what might rebuilding safety and trust look like in a GP setting? And then, Karen, if there is anything you want to add, I might give you that opportunity. Yeah.
Thank you. And I think that, Karen's given some really nice examples of how a GP can have a really long-standing relationship with individuals and their families and a community. So rebuilding that sense of safety and security, often a GP practice and other healthcare providers really provide a cornerstone of doing that. I'm sorry, I say that not wanting to put more pressure on you, but it is the reality. So thinking about when you're seeing an individual, what are the things that you can be doing to try to establish on a one-on-one basis around sense of security and choice and control? Any trauma takes away a sense of the world being predictable and things being fair and you being safe. Terrorism in particular really targets that, as Alex has just said. That's the whole purpose of it, is to really strip that away. So helping an individual rebuild that won't just happen immediately. It happens in ongoing actions and conversations. It's around encouraging choice whenever someone can make a choice. And it can be as small as saying something like, I think you would benefit from hearing more about or being connected to this service. Would it be okay if I gave you some more information about that? So rather than just deciding what a person needs, even though it might be really clear, but giving them a sense of control and agency, empowering them to be able to make some decisions as part of that. I know I'm using all the buzzwords there, but that's really what it is that we're trying to do. So thinking about, how can I help this person to rebuild that sense that this is a safe place, physically, psychologically? You do that in your office one-on-one, and you do that as a practice. It's the way that everyone in that practice then reacts and deals with people, a sense of knowing that information, when you're feeling overwhelmed, it can be harder to make appointments. It can be harder to remember details. Maybe you need to be telling people things, but also giving them a handout, checking their understanding of it. So thinking about all the ways that you individually, but you as a service, provide support for the individual. And I think also really emphasising with people that sometimes those small community things are really important. So this whole idea of doing the simple things, re-establishing good routines, connecting back in with the community, even though it might need to be incremental because it's scary, or people have concerns or anxiety. Sometimes the best things that people can be doing are not, intense psychological responses or treatment. It's the day-to-day changes and routines that people are re-establishing or really anchoring themselves into. Those things are vitally important. I think, that finally that it's that hope in recovery. People, even though they may still be really suffering and feeling like things are not getting better, we know that for some people the trajectory can take months, even years, as Karen so beautifully put. This is not just one incident that happened to many people. This is the cumulative effects of things that have been happening for months or years that people are dealing with. And we know how vital support is. So sometimes some people are easy to give support to. It can be harder to identify the people who really are vulnerable and disconnected. And sometimes it might take months and months of really giving that light touch support before some people will be ready to really discuss and admit to struggling with the aftermath of this particular incident.
Yeah, thank you. I just might want to pull out a point that you made early on, Nicole, because I think it's really important, that idea of being trauma informed, not just as an individual GP, as Karen is, but thinking about what does that mean for the whole service and the practice, from when someone first calls to contact the practice, or the forms and proceed, how many hoops are people jumping through, are we playing non-stop replays of the event on the news in the waiting room is a classic we see in post-disaster environments, and I suspect it was similar. So thinking about what brochures, showing that we spoke about physical safety, psychological safety, and I think that cultural safety, going to your earlier point, I think these are all things that you can look at communicating kind of from end to end, really, of the service. Before we start thinking about PTSD specifically, Karen, I just wanted to see if there was anything in particular that you wanted to add to what Nicole mentioned.
Yeah, thanks. I just wanted to say one other little point. I was talking about how diverse the community is, but there's two other points. One is we're very small. We're a very small population, but we're very connected. So you've probably heard the statistic. It may or may not shock you, but we're only 0.4% of the population in Australia, which is extraordinary given the headlines, honestly. It drives me totally mad, and let's go there. But in our area, in this Cesspin, we vary in some suburbs to, I think, 30% or more of the population to 7% of the population, and a third of Australia's Jews are actually in our PHN. So, and we're very connected. So we are family, and we. A lot of us, most of us, have got friends and family in Israel as well, and certainly have friends and family in Bondi, and certainly have, everybody knows somebody who was either injured or killed, or was very, very significantly impacted. And so just being aware, maybe not just to find out if your patient is Jewish, but what is your connection? Because I'm going to guarantee that there will be one. And that does make it a little bit more intense to deal with. And in some areas it's going to be even more so. So just, I guess I was thinking in terms of, being trauma informed and culturally aware, be aware that we do have a very visceral connection. We may try not to, but we do.
Yeah. No, I think that's a really important point. And as Nicole said, we know that kind of social support is actually one of the greatest predictors of recovery, but you're kind of almost showing that flip side of, well, thereby everyone knew someone who was there or impacted in some way. So that kind of social network is really strong. So I think you also, one of the things mentioned in your presentation, Nicole, was around, that it is only a minority that go on to develop mental health conditions. And it might be about now that we're starting to kind of put that hat on as GPs, psychologists, whatever our training is. And PTSD is just one of those conditions. I know it often hits the headline, but it is just one of those. But thinking of PTSD, what is it that GPs should be looking out for now? Any kind of just quick guidance on where GPs and others should be directing people for best practice support?
Yes, yeah, thank you. So, so post-traumatic stress disorder, you can't diagnose it until at least 4 weeks after the event. And then we're starting to see not just that people are reporting symptoms which are aligned with it, but that it's having a significant impact on their functioning, your ability to meet your responsibilities at home or at work, in your relationships. And, in post-traumatic stress disorder, the sorts of things that we might be seeing, it's avoidance behaviour that people perhaps don't want to think about or to talk about or go near anything that reminds them of the event because they get too upset and too overwhelmed by that. So they might not want to go down to the beach, or they cannot tolerate listening to or talking about it, or they don't want to watch the news for fear that something might come up about it. And again, it's now in the news again because things have started, that the judicial processes have started. So this is really a peak time for watching out what's happening. That we might see that people, there's lots of the hyperactivity in terms of their responses, feeling very agitated all the time, not being able to calm down. But they might also be talking about intrusions or flashbacks, distressing, feeling as if they're back there, that is happening again, really distressing dreams or nightmares. So, there's a whole heap of different signs and symptoms, but just be mindful about what people are telling you and how it's impacting. If you're thinking that it might be something along post-traumatic stress disorder, you can do brief screenings, things like the PCL5, 5 questions. We'll put a link into that for you. And it may be that it's just something, you don't even have to be formally giving that to someone, but you can be asking some questions around, is someone starting to indicate that these things might be problematic for them? It doesn't mean you need to, immediately make a referral or a diagnosis, but it might be something that you just start to monitor over the coming weeks, really starting to talk about what is it that you're experiencing, how much is it distressing for you, what are you most concerned about, and helping them to start to monitor it over time, because diagnosing something or being aware of something is one element. Someone wanting or being ready to do something about it is a completely different matter. So, it is important that if you are concerned about someone and you think that it might be post-traumatic stress disorder, that at some stage a proper and comprehensive assessment which is done, which looks at all sorts of different things, including their history of trauma and the meaning of the event for them, and how it is impacting for them at this point in time. We also look for comorbid things, of course, like anxiety, depression, substance use. Definitely what you don't want to be doing is thinking that it's PTSD when it's depression, because the treatments are different and they will not be effective. So we do diagnosis and assessment to be making sure that we're giving treatments. There are some very good treatments. There are evidence-based treatments which are available to people. We always think about starting people off with those first-line treatments. They're basically the talking ones that you want people to be getting into, the things like prolonged exposure, trauma-focused CBT. There's some very good treatments which are available, but have a look at the resources that we're putting up, PTSD guidelines, there's information through the Disaster Hub. But the final thing is that even if you, as a GP, for example, or a physio, whatever you might be, if you're referring someone on for a referral or for a diagnosis, you still have a very important role. Treatment and support is always best if it's multidisciplinary, and there continues to be people who are involved and checking in with that person and helping them to deal with a myriad things that they might be having to manage at that point in time.
Yeah, thanks, Nicole. And yeah, we've put a few things in the chat, and I think they'll be sent afterwards as well. And just thinking now, Karen, so obviously Nicole focused on PTSD and screening for that, but you're right there on the ground 2 months afterwards, figuring out who walking through your door is having these emerging mental health conditions versus their trajectory is more towards, okay, they've kind of got this in hand mostly. What are some of the things that you're using or finding that are helping you identify, who you need to be kind of dialing up that support for, or who you need to be linking in? Yeah, what are the things that you're looking for or noticing?
I think it's really interesting. I was very worried initially about the development of PTSD, and I was waiting for the 1 month mark, and so I could get the management in and change my mental health treatment plans from acute disorder to post-traumatic stress disorder. But in the same way that we counsel around grief, it's totally chaotic and it's all over the place. And I really liked how you introduced that, Nicole, and I've really seen that. I saw somebody this week who was there and lost a family member, and it was the first consultation, and I did very basic psychoeducation. I think GPs are really very, very well placed. I always say we're at the interface of mind and body. We are perfectly placed to do these assessments. We know how trauma and hypervigilance presents in people's body and in function. So I think we're constantly on the lookout for these kinds of things, and anybody who comes in will get that holistic assessment from me. And like Nicole said, I know the vulnerabilities for my patients, and I know exactly what you said around function, around intrusive dreams, around flashbacks, around increased levels of anxiety and depression. These are all the things that I'm watching out for, but it's not linear, which has really been really, really interesting to me. I've been in a quite privileged position to be working with some extraordinarily incredible community services. So I've had referrals of more vulnerable people. So I have been, kind of like you say, on the front line, doing those assessments. We've got beautiful therapists that we're working with too. And at this stage, they're doing exactly like you said, Nicole, the talking therapy, the standing with people. We're still in the resolving chaos phase, looking at Maslow's hierarchy, making sure people have accommodation and food. And we're only just starting to come out of that in some ways. But then, the other thing is, like you said, the community is incredibly resilient, and a lot of connection and meaning and spirituality. There's diverse communities that have been impacted, across Sydney, really. And so it's showing up in very different ways. It's probably not a good answer, I'm afraid, but just, I guess, to say, you know what to expect, but don't expect it. It's like it's very much, you really have to be very focused on the person in front of you. There are a few people that I've seen who I think, I'm going to be keeping a closer eye on, and those are the ones who are wanting to come back, who have got previous history of vulnerability, who have got the flashbacks and the nightmares are a really big one. In some of the reading I've done, they talked about peritraumatic dissociation being a risk factor, but I think a lot of people actually did dissociate a little bit. I think that was very common. So somebody said that to me, but I'm like, didn't everybody do that? I'm like, actually, it's probably quite protective. Our bodies are built with that kind of protect us.
To get us through the moment rather than think about that. And I think, yeah, it's an interesting observation that you've made, or a lot of different things there. And we've just had a question, and it's for you, Karen, but I'll open it to both of you. Just if you're seeing more distress with certain age groups than others at this kind of 2-month mark.
I don't think so. I know that the schools have just gone back, and there's been a huge effort in the local area to be watching out for our young people. And I've certainly heard of, children who are, what we would, label as acting out, whether, that's, that's a healthy response, or whether we like that terminology or not, I don't know. But I've certainly heard of all age groups, from babies that are unsettled to children that are sleeping with their parents to teenagers who may be more anxious and hypervigilant, to parents who really have had their safety shattered because they've had to look after their kids, life and death situations, to Holocaust survivors who are living with re-triggering of intergenerational. It's just no. So there you go. It's across the age.
That I think that's a pretty thorough answer, and I think I'm glad that question gave you an opportunity to highlight those developmental differences in reactions that people will be experiencing, and making sure that you're aware that how it looks for an adolescent is very different to a child, to an adult, and of course, experienced practitioners will be, but if this is their first kind of large-scale emergency that they're supporting a community through, just being really clear on those things as well. So aware, in a few minutes, I'm going to hand back to Chris so he can let people know about the various resources and services are available. But another really key part of being trauma-informed and being able to continue to support your community is finding practical ways to look after yourself, despite back-to-back appointments, working with really impacted and at times very distressed people. So I might, Karen, if you can maybe give a couple of ideas, and then Nicole, if there's anything that you wanted to add, and of course I'll put some more resources in the chat. But what have you, Karen, given that the reality of your work is, appointment after appointment, as you said, you've kind of had months of nonstop conversations. What practically, realistically, can you do to kind of try and sustain yourself through that period?
I'm just giggling because there's the answer that I know I should give.
I'm trying to tell you, tell me the real answer.
The real answer is I'm not actually very good at it. I canceled my holiday, unfortunately, but I am planning another one. I have beautiful colleagues in the area that we have been connecting with, having friends and colleagues reach out from outside the community has been really important and really heartwarming. And I would really encourage you to check in on anybody who's been impacted from the health professionals at the hospitals who had to deal with the wounds, to other communities who've really experienced trauma for their own cultural reasons, who've been triggered in the same way. And we understand what each other are going through, and reaching out to each other is super important. Time with family. Exercises dropped off, I'm afraid. But we're doing our best.
And I think that's exactly why the reality of it. Wouldn't it be nice if we said, well, look after this, and there is going to be give and take, isn't there? And it sounds like you've really prioritized connection as something that, okay, if I can do that, I can maintain this for a while. The holiday can wait, but you are planning the next one. But it sounds like that's one of the things that you've prioritized. Yeah. And Nicole, is there anything that you wanted to add? Any magic wand kind of well-being tip?
There's no magic wand. Look, I think that one of the vulnerable groups, or a group that we should just be really mindful that emerges over time, is that it's all of these people who have been holding this together, who have been part of the response, have been doing the community leadership formally or informally, have been caring for everyone else, have been putting their needs second. And this can go on for months, even years, but eventually sometimes these people also need support, or they need time to stop and have time to process and to make their own meaning. So it's watching out for that in yourself as well as in your colleagues, giving people space and permission to do that. And my biggest hint or tip is always have a plan B, maybe even a plan C around self-care. You are not going to be enacting the self-care plan you probably don't even have, even though as mental health professionals, we know we should have one. We usually don't. You're not going to the gym 3 times a week or eating properly or sleeping 8 hours a night. You need to pace yourself, but that does include having at least some strategies, working out what are the ones that you really try not to negotiate on. For me, I go, I need to get at least 5 hours sleep, or I need to at least walk the dog, or there are the things that help to keep me able to function enough to help other people. Have an idea as to what that looks like. We only do those things that we hold ourselves accountable, or to sort of have at least an idea as to what that plan B or plan C might need, because you're going to need to have that plan around for a long period of time in some instances.
And if you can use your colleagues and peers to hold you accountable to the plan, you might be working your way through to plan E, F, or G by that point. But I think you can kind of combine those things. But yeah, thank you very much, Karen and Nicole. I'll let Chris wrap up. But thank you so much for kind of sharing those insights. And Chris, I'll hand back to you to wrap it up.
Thanks so much, Karen and Nicole. That was such a great session. So your professional, your clinical insights, but Karen, just that community context, cultural context. Thank you for being so giving with that. I think that it helped out a lot of people in the session, and we're so grateful for that. So thank you, and thank you, Alex, for moderating the session in the way that you did. Really beneficial. So everyone, I'm just going to spend the last 8 minutes or so just walking through some supports that we've got on a PHN level, many of which you would probably be aware of already, but if not, if they're new to you, that's great, and hopefully they can be a really crucial support to people obviously experiencing trauma, but other mental health conditions as well. So the first one I just wanted to touch on was the Medicare Mental Health National Phone Service. So if you've used our Medicare Mental Health Centre to date, so our centre in Canterbury and now our newest one in Bondi, you likely would have used the National Phone Service. So the National Phone Service are the service that does the initial intake and triage. Got a range of trained professionals that can walk with a person through initial assessment and make sure that they get out to the all-important services locally in our area. So the best part for GPs and other referring health professionals is it's a completely free service. Like I said, it's staffed by trained clinicians that can walk alongside that person for the assessment. So that's the 1-800-595-212 number, and that's Monday to Friday, 8:30 to 5 p.m. So how that looks when that actually comes out to our centres in the Cesspin area is they're provided by Medicare Mental Health Centres. So like I said, most of you would be familiar with these. You probably referred across to them. But the great thing about Medicare Mental Health Centres is that they're multidisciplinary mental health teams. So you've got roles like psychology, social work, often mental health nursing, lived experience or peer work. So a whole range of professions that are represented. So no appointment or GP referrals were required, but of course GP referrals absolutely encouraged. And again, that's that number that I mentioned before that you initially make your call to, and that comes out via our Cesspin team to link people in to those mental health centres. So we've had one for a number of years now in Canterbury, so that's gone fantastically well, and that continues to grow. And we're really fortunate in response, obviously, to the Bondi tragedy for the government to make some funding available to stand up very quickly, I might add, through our team, a Bondi Centre. So that has its temporary address at the moment at the Junction Neighbourhood Centre. So that's run via New Horizons. And I believe that they're in the process of moving that to a larger centre, and that's hopefully going to occur by April. So just a little bit more on the new Bondi Medicare Mental Health Service. So the aim for this one and standing it up so quickly is to provide a trauma recovery focus. So many of the things that Nicole and Karen have mentioned, and obviously to support Australians impacted by the Bondi Beach attack. So there's a big focus on emotional stabilisation, resilience and recovery, and coordination via that multidisciplinary team with other local services to aid in wellbeing. So the centre opened on the 27th of January, and like I mentioned before, it's currently co-located at the Junction Neighbourhood Centre, and a full centre's looking to be established and open in the Bondi area by April. So obviously we'll keep everyone updated as to how that progresses. Another long-standing service that we've had throughout the community for over 10 years now is our PSS service, so our psychological support services. So this is psychological supports for people living within the Cesspin region. It is aimed at people with a mild to moderate mental health need or concern, and for people that generally benefit from short-term treatment. So it's not a long-term approach, or for people with more complex needs. And it's also for people that are unable to access schemes like Better Access or have financial hardship as well. And the range of other parameters for other groups with specific needs that you can read more about on our website. Headspace, I think, needs no introduction by this stage. People are probably well aware of the youth. It's the main youth mental health provider nationally for young people 12 to 25, young people and their families. So we're really fortunate in Cesspin to have a range of locations. So as you can see up here, we've got Ashfield, Bondi Junction, Camperdown, Hurstville and Miranda. And the support that Headspace can provide is really broad and fantastic work. So obviously there's a focus around mental health, but there is the capacity to help young people with alcohol and other drugs. And obviously the domains of life that are most affected by mental health conditions, so namely work, school and study. We also have a mental health service directory, and this is really aimed at GPs and health professionals that really want to hone in on the best possible service for the person that they're supporting. So it lets them use a range of parameters to do that. So one of the things that GPs and health professionals can really hone in on is that IR level of care. So matching it up with the level of care that a person might require, and it will suggest services accordingly on the IR. Obviously, give information as to where they're located, other key information around eligibility and how to link up with those services, and obviously how to refer. So I've had that for a number of years now. It's been really popular, and we continue to add to that. So to visit that one, that's mhdirectory.cesspin.org.au. So that is it for the services, and I think we've got about 2 minutes to spare. So I don't know if there were any other remaining comments, but again, I just wanted to extend such a big thanks to the presenters again tonight, Nicole, Karen, and Alex for moderating, and for members of our clinical team that have helped to put this on. Thanks so much for everyone for attending, and thanks again to all of our fantastic presenters.